Hi, I'm Steve Passik, and I'm a clinical psychologist from Memorial Sloan Kettering Cancer Center in New York, and I'm a consultant to the Pain and Palliative Care Service there. And my presentation tonight, and the issue that I'd like to just focus on for a moment, is the whole evolution of REMS, and try to contextualize that really quickly in the history of the last, say, 10 to 15 to 20 years of increasing opioid use in pain management. As many of you know, during that time period, the use of opioids has increased 4- and 5-fold. And largely that's been a very good thing, and many patients are getting access to opioid medications who need them, who might not have in the past. But at the same time, perhaps driven in part by the fact that the early way in which we spoke about expanding opioids tended to make little of or even trivialize the downsides of increased opioids in vulnerable people, there's been an evolving clinical response, and there's also been a governmental response. And that governmental response is embodied in something called REMS, or Risk Evaluation and Mitigation Strategies. Now those REMS can vary greatly from drug to drug, although a uniform one is ultimately due for long-acting opioids. I think by and large, REMS is meant to ensure safe use and meant to get the medicines to the right people, and in the case of the rapid onset opioids, that really means people at lower risk of abuse, addiction, and diversion, and those who are opioid tolerant. And I think a lot of us, when a lot of us find little to argue with when the elements largely focus on patient education. I think, though, when the hassle factor gets too high and doctors turn away from certain agents because it's just simply too time-consuming to go through the process to get those medicines and make them available to their patients, we all worry that appropriate patients may be denied access to those medicines. And so the jury is still out because the final plan for REMS has not really been approved or made obvious yet, and I think we all wait for that and hope that a balanced approach that doesn't play one public health problem off of another, but in fact looks at a way to balance them. And what I mean by that is not taking steps that are so geared towards trying to stop the problem of abuse and diversion, while then making the problems of people with chronic pain worse. So the jury is still out, as I said, and we hope to see the finalization of REMS programs in the near future.